This is a topic that is near and dear to many in the WEDI community, which is essentially how do we find the providers we need to work with in the interoperability use cases that we see today and we expect to see in the future, not the least of which is around no surprises, where provider specificity in terms of the convening provider, in terms of the treatment provider needs to be not only precise, but extremely accurate. Joining me today and joining us are Brian Marsella from Health Payment Solutions and Martin Cody, the Senior Vice President for Sales and Marketing at Madiket Health. I would also want to add that Madiket is a sponsor of the conference this time around, and we are very pleased to welcome them to the WEDI community and have their support of all the activities that WEDI undertakes. Martin, I'll turn it over to you.
Danny, thank you very much, and good afternoon, everybody. I will express my regrets for not being there in person and looking forward to the next time we can all convene together. There's just something about the in real life personal connections that can develop, but we're going to make do with the next best thing. And I appreciate the WEDI community for rising to the occasion and putting together this forum. It's working very well. I look forward to sharing some of the things that Denny just talked about. As he indicated, Martin Cody, SVP of Sales and Marketing, and with me virtually will be Brian Marsella. We'll get to Brian in a second. But one of the reasons that Denny just hit upon as it relates to why we're here is a little bit of an edit to the famous quote, "Houston, we have an accuracy problem." Now, in my day-to-day life, I meet with payers, with plans, with TPAs, with provider organizations every single day, and every single one of them just shrugs their shoulders and puts their hands up and says, we do have a problem. We aren't really confident in the accuracy of our directory. It has a lot of downstream impact and ramifications, and everyone on this call can probably articulate some of those ramifications far more elegantly than I can, but you know all too well that provider information is essentially the foundational building blocks of efficiency and member experience. And part of why we're here is HR 133. We could almost all quote verbatim kind of some of the areas of this comprehensive legislative package that pertain to each organization. It introduced a whole host of new characters and letters and acronyms, GFEs and IDRs and the such, and price transparency. But it really now has been in law for over 2 years, and it requires certain aspects of your provider information to maintain a attestation compliance as it relates to accuracy, and you have to respond in accordance with those compliance requirements. Michael, I would like you to go ahead and launch the poll question now. And the poll question is, and many of you have inside information on the answer to this question, but if you could guess what percent accurate do you believe the nation's provider directories are? And if you recall a survey that came out probably, I think it was 18 months ago, indicating the top 5 payers and what their level of accuracy were and the number of errors, it's a pretty daunting number. So I'll let that run while people continue to vote. And I'll move along and I'll tell you a little bit about how Madiket kind of approached this program and what it means to us. But as I said, the foundation of important and accuracy of provider information, it literally touches everything. And a little secret, I also sit on the provider information sub work group. I co-chair that with Michelle Berry from Availity. And as you can see, this is a slide that we're actually going to be producing as part of a work project, if you will, that we're releasing Provider Information 101. It'll be a series of 4 different releases. And we just took a snapshot of what provider information touches. And it is the foundational bedrock of your organization because it has so many downstream permutations, ramifications, potential for things to go bad when it's garbage in, garbage out scenarios. So I'm particularly interested in, if you're a payer, the call center volume that is on the rise. And we hear it from every payer we talk to. And there's an Aetna, we're very familiar with some of the challenges with regards to the call after scenario and the reduction of that. Call center volume spiking is a very expensive labor to try to resolve. The number one bucket for call center issues as it relates to the member directory is inaccuracy. Providers not practicing at the location he or she you said she was or they were. They are not in network. They don't have office hours. So there's a lot you have to do to become in compliance, and that's where we can help you. But it touches everything. So think about that as we move on.
Hey, Martin, real quick, it appears your screen is somewhat blocked to the attendee viewers. You might be
That could
running
be
another.
could that be the poll? Because the poll is still up on my end.
Oh, I closed it. Oh, okay. Let me see if I can close it again.
Or I can just minimize it.
Oh, yeah, if you can minimize it. Okay, now mine's off now.
Okay, good. I didn't answer the poll because I think I have inside information. So the provider information, as I was saying, it touches everything. And thank you, Michael, for that artifact disturbance there. Bills, insurance network participation, this is all germane to many of the environments you live in and working on a day-to-day basis. But this is coming from the sub-work group of provider information because we recognize that we have to get this right because it's going to help the members and it's going to help everybody. So Brian is a regional president or the president of a regional plan/network in Wisconsin. I, as Michael indicated and Denny indicated, run sales and marketing for Matikit. I also am a co-chair at the Provider Information Sub-Work Group. And also germane to this audience is I host a podcast for Matikit called The Edge of Healthcare, Lessons from Leaders to Use Today. And what we're trying to do as a pay it forward aspect is healthcare is an amazing industry. So $4.2 trillion, it's about 20% of the GDP, but there's a new wave of entrance into the healthcare environment and ecosystem, whether it's through new tech, whether it's through clinical, whether it's through operations. And we want to figure out a way to help those folks advance far more faster and higher in their careers than we did and let them learn from the mistakes of leaders. So if you have someone in your organization that you look to for guidance, mentorship, and you think they would be a good candidate for the show, it's a great opportunity to pay it forward. We've had some amazing guests. Most recently, Dr. Eric Bricker, who I refer to as the Energizer Bunny of clinical and hospital ecosystem content. But there's a lot of folks coming up on some episodes that we're dropping soon, and I'd love to have more input from great leaders. Here's where we focus. Michael, you have a question.
Yes, real quick. You're still having some visual issues on your screen. Folks are saying there's some black boxes on the top and bottom. You may want to stop sharing and then reshare. Let's see if we can get that fixed.
Okay, the black box on the top is this meeting is being recorded. So let me hit OK and get rid of that. Let's see if I can hide the floating meeting controls, and I appreciate the feedback. And let me know if that goes away.
I'd say click everything that's zoomed. There you go. Is that good, everyone? Give a thumbs up.
So Michael, you're going to be my eyes and ears because now I have no visible communication to the outside world.
No problem. I'll help you out. Denny's your moderator. He'll handle your QA.
Awesome. All right. So these are the areas that we focus on at Matikit. These are probably all numbers that many of you are familiar with. Provider sends your org some information on where she's practicing or added a new location or got rid of a location. You have to acknowledge within 24 hours that you've received that. 48 hours, it's got to be updated in the directory, and every 90 days, you have to attest that the directory has been touched, updated, and verified. These are the ones that brought the system to a screeching halt. And I still speak with today payers and provider orgs that have no idea how to comply with these requirements. More recently, in the last month, I was just at the Becker's Payers Conference in Chicago, and every single payer that I talked to, one-on-one, 27 of them intact, indicated we can't really do anything until the fines start happening because we have no idea how to solve it. Real problem, especially when you're talking about interoperability. So let's get into what Brian and his organization did as it relates to the HPS challenge. And Brian, by the way, and he'll tell you, is a lifer in this industry. Spent a long time at Cigna, spent a long time at Aetna, and so he knows exactly what you're experiencing. Excellent. Well, let's get into the heart of the matter on the HPS partnership with Matikit and all the things they're doing to solve the provider information attestation challenge, certainly around HR 133 and the No Surprises Act. And to do that, some of you may remember meeting Brian at the fall conference in Washington, D.C., but we're lucky enough to have him back here because I know he's really busy. And Brian, it's good to see you again. And I would like you, if you would, because you have one of the more impressive and storied careers on the payer side in healthcare, kind of bring people up to speed on what have you done on this side of the space, who you worked with, and walk us through kind of that history.
Sure. Hi, Martin. Good to see you again. And good to see the folks from WEDI. I've been in the industry for a little over 30 years. The vast majority of that was in different leadership positions with Cigna and Aetna. I also spent some time as a partner in a large consulting firm, Mercer, And I've been at my current company, which owns a network in Wisconsin, but is also working to develop some patient financing outside the state for about a year and a half. So I've seen the industry from a lot of different areas. I'm also the board chair of a nonprofit clinic that participates in a lot of entities, networks, and so I've seen a little bit of it from that side as well.
Basically a little bit of everything from all angles, so to speak. What drew you from those large organizations and you know, internationally known consulting firm to more of a regional situation and a regional payer / plan?
Yeah, what I really excited me about HPS Paymedics is that we weren't just looking to be a network. We were looking to actually solve a big issue for providers and for patients around how simple it is to understand the bills and the EOBs that they get, and how to make sure that they can afford those bills and EOBs. And that's really what HPS is and Paymedics is looking to solve. We've been doing it in Wisconsin for about 15 years, and we are now having conversations with different entities outside of the state to bring our solution to bear. What we're trying to accomplish is that they say 43% of Americans are avoiding or delaying care because they don't have the money to pay for it. And we're trying to make sure that's not the case. They get care when they need it, not when they think they can afford it.
Yeah, and you are probably have at your fingertips some of the statistics that are alarming when you first read them as it relates to, you know, X percentage of families are literally one medical bill away from bankruptcy.
Yeah, you know, they say 49% of Americans can't pay a surprise $400 bill if it came their way, and yet the average out of pocket is almost $1,800 across plans, and that's across all sorts of plans, including high deductibles. So if you're in a high deductible plan, it's even significantly higher. And you know, 63% of the folks have medical debt that have debt. So it is quite alarming that people aren't getting the right care in the first place. If they get it, they're having struggles to pay it back, which is then causing mental anguish and exacerbating their underlying condition. So that's what we're looking to try and to help solve.
It certainly needs solving. And you mentioned something in that answer with regards to a standard American family or an average American family couldn't handle a surprise medical bill of $400+ And so the Consolidated Appropriations Act, obviously one of the elements within that legislation was no surprise medical bills or surprise billing. And also some of the provider information requirements and accuracy of directories that when this came out and when you got to the organization, you and some of the senior leadership team took notice and said this could be a real challenge for us. So walk us through kind of some of those early meetings with the group and trying to comply with some of the NSA data requirements that you determined that we had to solve via an outside partnership.
Yeah, you know, I've been with the large organizations I was with had significant errors we knew in the provider directories. Some of it, things not getting updated properly, some of it not getting sent in to us properly. And with our focus being on, you know, not only ensuring somebody gets an in-network level of benefit, but to make sure that we can help finance that, I thought it was even more important that our directories were accurate than ever. And then I looked at the No Surprise Act, and it was putting forward, you know, let me start this over. As I was looking for, you know, at the No Surprise Act, the CAA, it had some pretty onerous timelines that were in place. You know, 24 hours to update a provider, 48 hours to make sure it was in the member directory. And also we had to attest that it was accurate, you know, every 90 days. And there was just no way that my organization could possibly keep up with that, given the size of the organization. And also we were a small player in the market. So the ability for providers to, you know, have the time to get back to us was not as high as maybe with some of the larger plans. And so when you think about that, but we're a small growing company, I had to find a way to take this and outsource it off the desk of my IT team, of my provider facing teams, and find someone that could really get this to a good spot, and also help us with the actual display of the information, because I didn't think ours was in a very good spot.
Well, and it's interesting too, because you talk about you're a smaller player in the market. Give us some specifics on kind of the size of your membership and number of members.
Yeah, so we've got about 60,000 members that use our plan through a number of different TPAs in the market. Got about 15 different TPAs that we're connected with. And we've got about 100 hospitals and a little over 30,000 providers on our plan. So, we're not big comparison to others, but we do, interact with a number of members in the Wisconsin marketplace.
And it's interesting from a directory and a member facing perspective. One of the things I hear on an almost daily basis in working with TPAs and plans and payers is just how critical and important that member experience is. When you walk through it for HPS, give us a little insight into kind of your perspective on that and why it's important to your members and the downstream impact that say inaccurate information can have.
Yeah, I think that if we do not have a provider in our network, then a member is not going to be thinking they can go to them and get the patient financing. And that may be the provider that they want to go to. So that's causing a bad negative experience. Or if they are not in our network and they're showing up there and they have a different expectation, then downstream we just get into a number of different issues. So, my view is someone should be able to go to the directory, know exactly who's in the network, what they get as far as financing associated with that, and then they can, enjoy the rest of the experience that we have, which is a consolidated bill and EOB and the no interest loans. But that needs to come after they've made a choice of a provider, and hopefully that provider's been in network for them.
My guess is it also might make it easier for you from a chief growth revenue officer and president of the company and in charge of bringing in new revenue to sell the services of the organization, knowing that on the back end, the provider's information is going to be displayed accurately and their patients and that new patients are going to be able to find them. Does that all go hand in hand?
Absolutely. Our 15 TPAs that work with us have an expectation that our information is accurate as well. So, we certainly owe that to the TPAs, to the employers, and most importantly, the individuals searching to get care.
Yeah, that's awesome. I also love the unique patient financing component of what you're doing. So, knowing on the heels of the families that can't afford a $400 to $500 surprise medical bill, and you guys actually have a patient financing solution to help them be able to afford that and get the care, certainly a unique aspect of what you're doing. So congratulations to you and the team for that.
Yeah, thank you.
All right, I am going to share with the group next just some of the details surrounding the success you've had to date, and then we'll try to make you more available. What if some of these payers and plans and groups that are watching this have a question for you? How do they get a hold of you?
Yeah, happy to talk to anybody. I'm just bmarsella@hps.md. And then happy to get back and engage with anyone. I'm on LinkedIn as well if folks want to reach out to me there.
Perfect. Brian, thanks so much for spending some time. Hopefully in fall of this year, we might do it again in DC with a couple other opportunities and some other folks that decided they want to tackle this no surprises challenge and get their whole process automated. So
that'd be great. I think when you think about the entry point of the system, this is so important for people to solve.
Agreed. We will chat soon. Thanks so much for the time. Appreciate it.
Thanks.
All right. So you got an inkling of kind of how they solved it. Brian as he mentioned, he's a smaller shop, 60,000 members. I know the IT constraints that they have. They've got a number of competing initiatives. They have a number of open recs for new IT people, and they have a gigantic staffing issue like just about every other organization in healthcare. So the reason why we've been successful in this area is partly due to the way we approach it. So if you look at how most of the industry looks at this provider directory accuracy and the conventional wisdom approach, they usually follow a multiple or any variant of these four paths. Brute force, they just try throwing bodies at this. The more people we hire, the more we'll be able to get this into scale. They've tried this for years unsuccessfully, and as I said, there's a staffing issue. This is also expensive and labor intensive, especially with turnover. And manually entered data is the longest tenuous process and also the most error prone, so brute force isn't really viable. Big data. there are a number of entities out there that indicate, well, we have 50,000 provider data information sources, or 100,000 is one I've heard recently. They have access to 100,000 provider data information sources. Not certain the authenticity of all of those sources, but that's great that you might have access to a lot of data, but that data is historically a snapshot in time. It could have been from 2 weeks ago. It could have been from 6 months ago. It's not current data. And also, it is only the data side of the equation. It's not necessarily the compliance side of the equation. So having a lot of data isn't always an end-all be-all solution to make this efficient and scalable and accurate. Then you can pull data from the payers. And Brian indicated, sometimes their information is inaccurate. They don't have a way to scrub it internally, and they receive it oftentimes inaccurate. So not necessarily a reliable entity there. Credentialing vendors, it's an understandable source, but that's a process that happens every 2 to 3 years. So some of that information is also 24 months old. So that's 1 or 4 ways, or a variety of 4 ways to do it. And I think that is also part and parcel to why this hasn't been solved, because the old way and what got us in this situation is not going to get us out of this situation. So pictorially and visually, this is what that process looks like. Easily a 3 to 9 month manual process. It requires batch approvals. It does happen, systemically with a cadence. It can be monthly, it could be quarterly, but usually the data is curated about every 2 to 3 years when you start talking about all the external sources. People send in rosters. They have batches of outbound faxes. That information gets sent to the health plan, not necessarily whether or not it's accurate, but it gets sent to the plan. Providers are often asked to self-verify the data, which takes time out of their day when they could more effectively be seeing patients, which is, I think, what we all want them to be doing anyways. And then this usually produces 50% accuracy. And Michael, I'm curious if you could break down the buckets of respondents to determine, what was the lion's share of the audience's belief of the directory access or accuracy in the United States. Do you have that figure?
Yes, I do. 24% felt it was 20% accurate. 34% felt it was 40% accurate. 21% felt it was 50% accurate. 17% felt it was 70% accurate. So the majority group was 40% accurate.
So if I'm loosely going after 24, 34, 21, 8, 1, 9. So it's nearly 70% of the respondents believe that the accuracy is currently, and I'm not too far removed from academia, an F, 50% or lower. That's a problem. We should and can do better. And I actually believe you. I agree with you. It is that level. So where do we go with a 50% accuracy rate? And it's ironic. I've actually worked with health systems that say in that first bucket where 24% of the people said it's 20% accurate, they believe and have set forth initiatives that they want to get up to a 50% accuracy rate, which I guess if you're 20% is a good bar, but you're still striving for failure. You're still striving for 50% accuracy. Think about that for a moment. There's really no other area in life where you would be teaching people, your children, okay, just go for the F. Well, maybe baseball. Because if you get on base 5 out of 10 times, heck, if you get on base 3 out of 10 times, you're going to be in the Hall of Fame. But in healthcare, we need to do better, and we can do better. So Matikit has a bunch of different data sources that are unique in the industry. We also have some processes that we bring to bear at speed and at scale from an accuracy perspective and automation perspective. So we use a curated attestation process, which requires us from an automated standpoint to engage with the provider office. We focus on the end user experience. We have a 70% success rate on these long tail provider orgs. I'm going to show you some tables here in a second. Data sourcing. Many of you know in the audience that Matikit basically got us started by doing EDI automation. Some of you in the audience are customers. Our EDI automation platform is inside many major clearinghouses and has been for 12 plus years. So as a result of that, we have access not to 100,000 data sources, but to a very, very real, current, fresh data source, the provider's information. Keep in mind, if a provider is going to change a location or move out of state or open up a behavioral health practice, the first thing they're going to do is want to get paid electronically. They're going to fill out an EDI application. They are not going to update, unfortunately, the MPES directory. They aren't going to update CAQH right away, but they are going to make certain that the money is flowing freely and with as little amount of friction as possible. They don't want paper checks. So from that standpoint, our EDI platform and payer enrollment platform has very current provider data. Data ingestion, you heard Brian mention this. A lot of times, payers and plans get information from provider orgs that's inaccurate. They also get it in a variety of formats, and each payer and plan wants the organization to send it to them in their unique format. We don't care what format it is. We will take all formats, we will consolidate it and get it into the appropriate format for endpoint sharing, and more on that in a minute. Data delivery, we'll send it anywhere you need. If you're interacting with 50 plans and each one of those 50 plans has a unique setup and format for how they want their roster or their data sent to them, we handle all that. That would require an army of labor, normally on the organization's end, to configure all that and then send it all out. But that's exactly what we do to help free up some of that time. And our payer enrollment platform, our provider data exchange platform, all of these things continue to feed each other from a provider information and data ingestion perspective, that the data is always getting curated. So visually, here's what that looks like. A little bit different than the standard conventional aspect in the industry. So all of Medicit's data is front-loaded and augmented by the provider rosters, all formats. And again, we don't care. We refer to this as crudely the Statue of Liberty approach. Give us your poor, your huddled masses, your unstructured data. We want it all. We'll take care of assembling it in the format that's required. And that includes all your outbound emails, your inbound Zendesk tickets, where a provider calls in and leaves a voicemail that says, I've got a new office location. We get all those, we intake that information, we transform all that data into a standard schema. Underneath the covers, we harmonize and then standardize that data, and then we create a master data set. That gets you 90% accurate. From there, the output of this gets daily freshness checks. So we are constantly curating it with some external sources that have high confidence ratings of the data. And then we also can then take this information via outreach to the provider groups and orgs, via custom secure portal, and we can send this to any endpoint. That's the unique thing about it. You want to send this to 25 or 30 payers in their format? Not a problem. You want to bounce this off your CRED system and make certain that that's updated with fresh, pristine provider data? Not a problem. And then the attestation process is also internal. But here's specifically as it looks at Brian's. So Brian and their group cemented the partnership in December. We had a late December kickoff call and really started things rolling in January when people got back from the holidays. We sat down and worked with them. And this, by the way, is their independent provider orgs. This is not rosters. So these are those onesie, twosie, ad hoc ones that are the bane of every single plan and payer's existence, where the 3-doc practice calls in and they added 2 more locations. And there's a high percentage of these. But what I want to call out is we broke these down into separate cohorts with the collaborative process of HPS. And so cohorts 1, 2, and 3 are all less than 3 docs. Cohorts 4, 5, and 6 are greater than 50 docs. And there's a blend that we work in between. So cohort 1, you can see very quickly by looking at the table, we have 83 organizations in this cohort. There's also 83 providers in this cohort. So a quick math lets me know that these are all single doc practices. They have an 81% attestation rate since April 4th. So we began this process in the outreach April 4. Cohort 2 was begun April 8th. Cohort 3 was begun April 20th something. So as we blend some of these cohorts and providers and contacts fall out of the system, they get added to future cohorts for different methodologies of outreach. One of the things I want to call attention to is the total attestation completion rate since April 4th. This is what are we, 6 weeks later, and we're at nearly a 65% attestation rate for over 5,000 providers. That is extremely fast, and it's extremely repeatable, which is what's important to all of you. This is something that can scale, and this is something that continues to improve week over week as we get more and more data in. So that 64% in 2 weeks is going to be upwards of 75%. And then it just continues to build on itself. That again has the exact same downstream positive ramifications that Brian said his organization was trying to forward from inaccurate data. Similarly with rosters. Rosters have, and I've blocked the names of the healthcare systems that they're working with, but you can see some of the size of these, 1,000, 1,800, 1,300, 2,000, 5,000. These are some potentially gnarly rosters, as some of my IT brethren like to call them. Columns everywhere, hanging data all over the place, and it's very tough to standardize these things. all of these rosters now that we receive on a monthly basis are getting attested. So this has a cadence with it where the system is intuitive enough that at a certain timeline, usually about 73 to 75 days, without contact from the org, the system wakes up and pings them. And it looks something like this. This is just one screenshot. Here's a group they didn't answer the 75-day ping. They didn't answer the 80-day ping. They didn't answer the 85-day ping, either via email or phone call. And so now we're at 94 days. So every one of these folks hasn't been attested to in 94 days. This then kicks off internal business processes that have been designed with Matic and HPS collaboratively to say, what do we want to do with this information? We've now shown them in 6 weeks that they have over 100 different organizations that have no contact with just about 300 to 400 providers that are listed in their directory, some of which we've now asked them to compare with claims data. So the claims data is interesting because now I can take an NPI, I can see what the claims are, and many of those 100 plus provider orgs, there have been no claims issued for these NPIs in over a year. So that could mean a whole bunch of things. It could be maybe that provider just didn't see any patients at that location, but it could also mean that provider is not in the network any longer and probably should be removed from the directory. So the net of it all is it's giving them very real, accurate insight to be able to make business decisions based upon their own data and not kind of, well, suppose the data is accurate. If it's 30% accurate, this gives them very real intelligence to be able to make verifiable decisions for the organization and then get those providers out of the network if they are no longer in the network. This is a question that we get asked all the time. How much could this be worth to your organization? This is a simple answer. You can go to maticathealth.com ROI right now, and if you're a payer org or a plan, there are 9 fields for you to enter. And consistent with our theme to make it easier for provider orgs, there's only 8 fields. And these are fields that most folks working at a payer know off the top of their head. There's not anything you have to attach or it's really high level stuff. And then when you click see my ROI, it's going to show you the data. It's going to show you the number. We're not going to gate it with any type of, oh, please send us your email and social security number and mom's maiden name. We want you to have the information. If it's a compelling enough number, which we think a lot of it will be, give us a call. Go ahead and put in your email and we can walk through the math with you and walk through the speed with which you can start addressing this challenge. It's very real. I haven't seen a lot of improvement in the industry in over a year. It's definitely something that is known to be a problem. And what Denny said as it relates to interoperability, this is the hallmark and the foundation to help that process along. And it's what we do. We're simply here for you to make this better. And we look forward to any and all ways to help with the provider information accuracy. I will now happily take a sip of water and open it up to questions.
Thank you, Martin. Those on the call, please enter your questions into the chat box. I have several of my own, but let me start with Rob Tennant from WEDI. What do you think are some of the causes for provider reluctance to update their information with their payers? Martin, did you hear my question?
Oh, sure. Yeah, I'm sorry. I thought my bad. I think part of the reluctance is time. It is, at the October conference, there was several provider orgs there, and they're just exhausted. You talk to the provider orgs now, this is just one more thing for them to do. But if you can make it easier for them and they can see immediate impact, and I mean immediate, it's like instantaneous, my data is updated, I don't have to do anything for 90 days, versus some of the things that they have to do where they get asked to do this survey, they get asked to participate in this, they get asked to, and they don't get to see the downstream impact of their efforts right away. So when they get their data updated through the Matic tools and platform, there's an immediate ROI. And more often than not, the information that's getting sent in that outside of Matic, when we ask questions like, is it accurate? The number one answer we get is it's good enough. Well, no, it's not good enough. And attested doesn't equal accurate. And that's something that people are slowly beginning to recognize. You get a 1,000 doc roster in and someone just checked the box that said, yep, we attested it. They haven't looked at it. So we need to do better on the front end because it's still true garbage in, garbage out. And that's where we kind of roll up our sleeves and get into the nitty gritty. And once the physicians see things are happening and moving in a positive direction, and that their patients and net new patients are going to be able to find them and see the office hours, because we feed this information to directories, and we actually help organizations design their directory upon sometimes CMS requirements and also for the commercial requirements. So that has an immediate impact. That would be what I've seen from observation. Great question, though.
Thank you. Devin Hunter asks, what types of comprehensive payer reports are you able to generate with this solution?
That's also a good question. The solution, we're partners with AWS, and we've got their reporting module, QuickSight. We can report on virtually anything in the system. I can tell you by payer, by plan, by TIN, by NPI, how long it's taking, who's responded. I mean, there's a great deal of information at our fingertips, all of it designed to say what is going to help you as the organization that's meaningful. You know, we don't want to inundate people with reports. We'd like to give them some data to help make better informed decisions to improve the accuracy of all downstream processes. And it's part of the process. It's iterative. It's not a one size fits all. We have a bespoke process with every single payer and plan that we work with. And it's also something I see Janice's question. Payer reporting errors are patient reporting errors, I'm sorry, are a little bit tougher to quantify, but we do factor them into the overall model, because the patient reporting errors are typically via the call center. And every payer that I've talked to, their call center volume has spiked in the last 12 months. And the number one bucket that we hear that they tell us is the information on your directory is inaccurate. I went to that provider's office, they aren't even there. They aren't taking new patients. The largest bucket of growth for call center calls is, in fact, inaccurate directory information on the website.
Thank you. What are some of the technology innovations that you see coming soon that will advance your ability to increase provider directory attestations above 90 and approaching 100%?
It's a great, I mean, has anybody ever heard of AI? That seems to be the buzzword du jour. But I think AI can play a role here, because there's some large language models that can also play a role. There's some machine learning, and we use, you know, some of those tools as well to say, okay, if it's looking like a duck, sounding like a duck, quacking like a duck, this is pretty much a duck. This provider, this NPI hasn't generated a claim in a year. We look at a lot of different data around that, and I don't see any magic wands, though, if that's what you're looking at, to say, oh, we can clean this up and get to 95% accuracy in 90 days. It is an ongoing process because providers are moving all the time. So you have to have it be static and efficient. And I mean, if someone knows of a tool out there, let us know. We're all ears. We work with a lot of third-party organizations that have some sophisticated tools. And so we bump our data up against some of their findings and score all of that data. But it's a constant effort to get as close to 95% accurate. I don't think you'll ever achieve 100, just because the data is in flux.
Very good. Rob Tennant asks us, do you anticipate the No Surprises Act directory requirements will move the data quality needle somewhat or significant?
Two-part answer, yes, but only if the stick is enforced. Once the fines start coming, then the data accuracy will skyrocket. I hear it from payer and plan and provider org every day. Can't do anything, don't have the bandwidth, way above our tech scope, don't have the internal rails. We're trying our best. I've got, you know, a dozen competing initiatives. And until the fines start rolling out, via kind of like the old meaningful use aspects and the Medicare payment enhancements, and then the Medicare payment penalties, if you will, for meaningful use EMRs, there needs to be a carrot. I don't see anybody really doing this to move the needle significantly, Rob, for accuracy of the goodness of their hearts. They'll do it to avoid the penalty at the pocketbook. I wish it wasn't true, but money seems to be an ultimate motivator.
Money does speak. We understand that. We appreciate that. When you look at provider directories, we often, it's sometimes like a projective test. Many of us think of provider directories as different things. And perhaps you can help us understand some of the distinctions. We have provider directories that are used by patients to find providers. We have provider directories that are used by health plans for certification, enrollment, We have provider directories that are used in HIEs to enable HIEs to manage a large bolus of providers within their network. Could you talk a little bit about the provider directory rubric and what fits under that and where Matiket fits specifically? It's one of the questions I keep coming up with respect to provider directories.
Yeah, we haven't done ourselves any services, have we, by introducing this many definitions of a
Of one
simple
term,
entity.
right.
Of one term, exactly. It's like if you ask someone, what is provider information? And which is what we recently did and got about 10 different answers. The directory, there is a consistent theme. It's with regards to what it is. And obviously it contains demographic information pertinent to the individual care provider. It also then gets extended on beyond that with regards to location information. Then it gets extended on further for the entity's own individual needs to include other things as far as practicing locations, languages spoken, office hours, accreditations, educational history. So each one of those organizations that you mentioned has a different, I guess, fundamental requirement of some variation of all that information. But at the core of it, it's still provider directory is the curated aspect for your organization of the elements you need. That's the directory. And that directory will change based upon the organization. So, but the core of that, the core tenets of that directory are the same as it relates to some of the demographic information for that specific individual. It just gets more broader with more terms and more fields of data dependent upon the organization that is sharing that information with other entities and their requirements either by their own policy or also state, local, federal policies.
I have one additional question, and that is, and I'm sure you get this question almost daily, Martin, but this sounds like a blockchain case par excellence. Multiple ledgers, multiple different, unique endpoints, some responsibility for the endpoints to keep their information up to date. Are you looking at technologies like blockchain or other tools that will enable this kind of one-to-many challenge that we have in maintain an individual organization maintaining a huge provider directory, of putting some of that technology in the provider's hands, so to speak, so they're able to maintain and keep their directory up to date? Do you see that in your future, or do you see that playing a role, or do you see your model as being sufficient to make those kinds of adjustments?
Oh, no, I absolutely see that in the future. And I agree with you 100% that this is tailor-made for some of the blockchain capabilities. We're a technology data company that happens to have a provider data management platform. So as a technology data company, we are constantly scanning the ether for other like organizations that have the next greatest sophisticated mousetrap, if you will. And then there's a bunch of things coming that we see that could play a significant role in this. But one area that I haven't seen the adoption that you just mentioned is the physician side owning the running of this data and owning the methodology to get to the accurate directory. Our data and our experience is that the physicians, they just want to see patients. They want this to be taken care of for them, and I don't blame them. This is complex, this is hard, and it's very important, but they also want to see patients and they want to get paid in a timely fashion. So I don't know, outside of maybe a few teaching orgs and stuff like that, and the larger provider organizations where they want to entertain bringing this in-house, most of the folks just want this problem to be solved so that they can practice clinical care.
Well, Martin, I want to thank you. I want to thank your colleague. I want to extend our appreciation from WEDI for what you've shared with us today. This is a subject that's near and dear to our hearts. And I know we look forward to hearing from you and Matiket further.